Hello and good afternoon, and welcome to this week's instalment of the NDARC webinar series. My name is Daisy Gibbs and I am a PhD candidate at the National Drug and Alcohol Research Centre, and I'll be your host today. I'd like to start off by showing my respect and acknowledging the traditional custodians of the lands throughout Australia where we're all joining this call from. For me, this is the Wurundjeri people of the Kulin Nation. I'd like to recognise their continued connection to land, water and culture. This land always was and always will be Aboriginal land. Sovereignty was never ceded. We pay our respects to elders past and present. Today, our presentation will be discussing findings from a systematic review of the literature from 2000 to 2022, which examined extended release pharmacotherapies for substance use disorders in criminal justice settings. We're really lucky to have this presentation from Dr. Amelia Woods. Amelia is a second-year PhD candidate and a medical doctor based at Drug and Alcohol Services, South Australia. She completed her Master's in Addiction Behaviours in 2018 and has since held roles conducting research and supporting medical registrars in conducting research. In her clinical roles, she has worked as a GP in the Aboriginal and Prison Health Services and continues to work and research at this intersection, delivering addiction medicine, particularly for Aboriginal and incarcerated clients. So we're really lucky. We've got a great perspective for this novel research. It's going to be a great presentation. We're also very fortunate to have two panelists joining us for the Q&A afterwards. The Professor Adrian Dunlop has over 24 years experience as an addiction clinician and clinician researcher. He currently serves as the Director and Addiction Medicine Senior Staff Specialist with Hunter New England LHD Drug and Alcohol Clinical Services. He's a conjoint professor with the School of Medicine and Public Health at the University of Newcastle and a member of the Centre for Translational Neuroscience and Mental Health at University of Newcastle and Hunter Medical Research Institute. We've also got Dr. Catherine Foley, who is a psychologist and postdoctoral researcher at NDARC. She has a clinical background in mental health, substance use and trauma, and her research has a focus on working alongside communities and health providers to co-design and evaluate holistic health services. So throughout the webinar, please use the Q&A function to pop your questions in, and we'll try to get to these all at the end. I'm sure it's going to be a really interesting presentation with loads of questions, so we may not be able to get through all of them, but we'll do our best. And without any further chat from me, I will hand over to Amelia if you want to turn on your camera and microphone.
Thanks so much, Daisy. So thank you everyone for joining me to talk about my systematic review looking at extended release pharmacotherapies for substance use disorders in incarcerated populations. Daisy's just done a wonderful acknowledgement to country, so I'll just add quickly that I'm joining you from Ghana country today, and I want to acknowledge that sovereignty has never been ceded. It always was and always will be Aboriginal land. So as Daisy kindly mentioned in the introduction, I've long held an interest in working at the intersection of Aboriginal health, criminal justice health and addiction medicine. And after many years of training, I was finally in a position where I was working at this intersection. And while I love the work, I was noticing that there was, from the various workplaces, a kind of a missed opportunity where the courts would release a patient kind of unexpectedly from prison, and we may, in the health system, may have not made a clear plan about how that person would access substance use treatment in the community. And so we would sometimes come in and find that they had been unexpectedly released without a kind of clear plan about where they would be accessing treatment. And I was on the receiving end of that in my roles at the Aboriginal Medical Service and in the drug and alcohol field as well. And in those services, we would kind of sometimes feel a little bit scrambly trying to organise things for these prison transfers, trying to get everything sorted in time for them to be able to access treatment. And I also saw quite a bit of loss to follow up, unfortunately. So not only was it kind of complex for the services, but it's a very complex time for the patients who are at this intersection as well. So these patients are adjusting to life on the outside. They may be battling with the re-emergence of shame and trauma triggers and navigating different systems and health professionals. And amongst all of this, a number of clients may experience difficulties attending clinic or continuing with daily dosing of medication for their substance use. It's also important to consider if someone's been incarcerated for a prolonged period of time and they've had limited access to family and friends, whether we can always expect one of their first priorities to be to go and access a prescriber or provider in order to access the treatment, especially among all these various kind of roadblocks and others. So it was also around the time that I started working in the field that the extended release pharmacotherapies really started taking off. And I could see the benefits of the extended release buprenorphine it was in each of the settings that I was working in. It was also around this time that I was looking to get more involved in research. And so I really wanted to explore the role that the extended release formulations may play in the treatment of the population of individuals who sit at this intersection. So I started a PhD investigating their utility and started off with a systematic review looking at extended release pharmacotherapies for substance use disorder in incarcerated populations. So a bit of background on this topic specifically. So this is one of the prisons that I've worked at. This is Yatala Labour Camp down here in South Australia. And here, like many prisons, substance use disorders are very common among our patients. There are many types of addiction issues within this service, but this talk will focus kind of primarily on alcohol and opioids. And that's because the extended release formulations that are currently available can be used to treat those two specific use disorders. So if we're thinking about alcohol use in prisons, around 2/3 of people in prison who drank in the 12 months prior to arrest admitted doing so at hazardous levels to their health. And thinking about heroin, there's about a 41% lifetime use of heroin in the criminal justice system. And about 44% of those people who had used heroin at some point used daily or almost daily in the 12 months prior to incarceration. So quite high percentages there. And despite those high percentages, only about 13% of people leaving prison in Australia have accessed alcohol, other drug or AOD treatment while they were in prison. So quite a small percentage and a big missed opportunity, I think. So unfortunately, Aboriginal people are overrepresented in the criminal justice system. And while many Aboriginal people have really wonderful support structures, including close family ties and deep cultural links, the effects of colonisation, intergenerational trauma, racial disparities, and systemic racism have resulted in some areas where there are significant issues with substance use in Aboriginal populations. So I just want to pause here for a second and acknowledge that we were really hoping in this systematic review to be able to look at treatment for Aboriginal clients specifically. But we anticipated this and it came to fruition that there just weren't enough studies to be able to do that, unfortunately. So we were looking at First Nations clients, hopefully generally, but also around the world, not enough studies to be able to do a review on that. So instead, what we've done is do a review of the general population, and we're hoping that that will be a starting point for future research and lessons on treatment options for Aboriginal people, so that further research can be done so that treatment for Aboriginal people can really vastly improve from its current state. And I just want to acknowledge that the treatment for Aboriginal people really does remain a key focus of my final thesis. So it's still a very strong interest area of mine. So we've talked a bit about the addiction issues. I just want to talk a bit about treatment. And so as I've already kind of mentioned, this talk is going to be focusing on pharmacotherapy. But pharmacotherapy is by no means the only treatment modality. So it's hugely important when assessing patients with substance use issues and making a relapse prevention plan for them to be thinking about a biopsychosociocultural framework and trying to hit each of those areas kind of dependent on the individual. So working out whether the kind of psychological trauma is driving the real reason for use, and really addressing that is incredibly important. But pharmacotherapy is an important first step for many people, particularly for people involved in the criminal justice system. And this is because on release, there's very high rates of relapse, and there's also very high rates of overdoses for opioids, among other challenges in that post-release period. And so some of the pharmacotherapies that we have can be useful in that period and in general for kind of managing withdrawal, managing cravings, and in some cases even reducing those overdose rates. But while the pharmacotherapy has, been a real mainstay in the treatment plan for many patients, there has been a barrier that's been long recognised that many of our pharmacotherapy options have been daily or at most second daily dosing. And so the fact that the client is having to take that medication and potentially even pick up that medication from a pharmacy daily is very resource intensive for clients and clinicians, and particularly so in the prison sector, and means that treatment can be quite rigid and inflexible for patients as well. And so it's on that backdrop that extended release pharmacotherapy has been looked at for a number of years as an option, and really in the last few years has taken off with extended release buprenorphine coming in. So there's a great chance for these medications to have considerable benefit in assisting barriers to accessing pharmacotherapy, particularly in the criminal justice system and on that post-release kind of period. So these are the two extended release medications that we currently have available to us kind of internationally. So extended release naltrexone, that's available as an injection and an implant. Naltrexone is a mu opioid receptor antagonist. And so it's used for both opioids and alcohol. When it's used for opioids, it's used as a blockade. So it sits on the opioid receptor and stops other opioids like heroin or endone, things like that, being able to have action. And so it just sits there and blocks that other medication from coming in, or substance from coming in. When it's used for alcohol, it's got quite a different kind of modality. So it's really more there just kind of reducing the reward from drinking, as well as reducing the cravings down in a certain population or percentage of the population. And then if we're thinking about extended release buprenorphine, which is available as an injection, that's quite a different medication to naltrexone. So that's an opioid agonist. So that works in a very similar way to heroin and other opioids. So it goes into the receptor and creates firing off and creates kind of the same kinds of effects as those other opioids. But it's got a much longer kind of half-life, and it's much more stable in the blood. Which means that people don't need to use as frequently, and it can just kind of give people a feeling of normalcy. But we'll talk about that a bit more later as well. And there's quite good evidence base with positive outcomes from the buprenorphine. So both the extended release in the general community and also sublingual buprenorphine, which is the daily dosing formulation in various settings. So they're the two medications that we'll be looking at in this review. So my key objective in the review is to identify and analyse the evidence for the use of the two medications for people leaving the criminal justice system or kind of recently in the system, currently in the system, to better understand the efficacy of the medications on relapse prevention and recidivism outcomes. Our hypothesis going into this was that the extended release buprenorphine, so that agonist treatment, was likely to show an improvement in relapse prevention outcomes. We weren't sure what we were going to see in terms of recidivism. In terms of the naltrexone, the blocker, we were thinking that we would probably see some improvement in some of the relapse prevention outcomes we were looking at, such as retention in treatment, maybe an overdose, but we weren't expecting a huge amount in the other outcome areas, which we'll look at shortly. So onto the methods of my search. So this was a PRISMA compliant Prospero registered search with the following search terms and eligibility criteria. So we wanted to find studies that were looking at people who had substance dependence, who were on relapse prevention pharmacotherapy that was long acting, which we defined as requiring dosing after 5 or more days. And they were either in a prison setting or had recently been released, which we defined as less than 3 months. And we had some additional filters as well. So we extracted a number of variables, but these were our core 5, and we'll cover them in more depth in the coming slides. But we're looking at substance use, overdose, recidivism, adverse events, and retention and treatment. We also did risk of bias assessments on each of the papers that we included. And I'll speak to this more a bit later, but essentially this is a measure of how accurately the studies have minimised any biases that might impact the results. But we'll go into a bit more depth of those later. But just to let you know that we did use about 6 different tools according to the study design. So I'm now moving into the results, and I just want to flag that here I'm going to present the state of the current literature. And in this section, I guess it's important and helpful to keep in mind that this is extended release pharmacotherapies are an emerging treatment. And prison is a challenging area to conduct research in the first place. So the literature we're looking at is going to be quite limited. However, the lack of evidence here is not the same as evidence of effect or non-effect. It simply indicates that we need to do more research, and this review gives us the opportunity to think about the kind of research that will help in this space when we're moving forward. So initially we found 356 articles, which came down to 143 after removal of duplicates, and of which 24 met inclusion criteria after abstract and full text screening. So if we're thinking about, when we're looking at the studies that we did include, we found 16 papers looking at extended release naltrexone, 7 papers looking at extended release buprenorphine, and 1 study looking at both. But the study looking at both was an economic analysis. And so we're not going to discuss that in depth today because it wasn't one of the 5 core outcomes that we were looking at. So in terms of the demographics of the study, so most of the studies came from North America, Europe, and Australia. There was a male predominance amongst the study, and the sample sizes ranged quite massively, so between 15 and 2,000 included in the quantitative studies. The mean and median ages ranged between about 34 and 46, but it wasn't mentioned in a number of studies as well. And the ethnicity was predominantly African American, but with a number of other ethnicities mentioned. Importantly, Aboriginality was mentioned in a subsection of 1 study and was about 40% of that sample. So if we're looking at the methods of the different studies, so we can see that there were 11 RCTs, but it is important to note that while there were 11 papers included, it was actually 11 papers, but 8 studies. So there were 2 papers published from 1 study and 3 papers published from a second study. And each of these papers met inclusion criteria because they had new outcomes and new results that we wanted to include, but the study was the same original one with the same participants. We also had 4 cohort studies, 4 secondary observational analyses, 3 economic analyses, 1 retrospective chart review, and 1 qualitative study. So when we're thinking about diversity, there was considerable diversity across many aspects of the studies that we included in this search. So there was a lot of diversity around comparator interventions. So the extended release formulations were in some texts compared to the sublingual formulation, so extended release buprenorphine compared to Suboxone. But in others, they were comparing, say, extended release naltrexone to methadone, some to placebo and some to treatment as usual. So creating comparisons across those kind of comparator groups is quite complex. There's also a lot of diversity in outcomes. So if we're thinking about substance use, some of the substance use outcomes we're looking at time to first use. Other papers would look at the number of days of use across the study. Some papers in terms of recidivism were looking at reincarceration, while others were looking at rearrest. And the outcome measures also varied quite a bit. So some were using timeline followback to assess how much opioid has been used, while others were using positive urine drug screens. There was also diversity across the participant characteristics. So there was considerable kind of diversity around the population as to whether some of them were on existing treatment, whether they were offered treatment but had refused it previously, and what their treatment preference was. So that again made it difficult to kind of compare across studies. There was also methodological diversity. So we'll see the risk of bias scores shortly, but there was quite a range there. And the sample sizes varied massively as well. So this is the risk of bias assessment. And as I said before, this is a measure of how effectively the studies have minimized factors in the design, conduct, analysis, and reporting that could have led the intervention to be underestimated or overestimated. So it's kind of trying to work out how true that effect is, how likely it is that we're measuring a true effect there. And includes things like participant and researcher blinding, how the randomization process was done, and all sorts of other things besides. And once you've done that assessment, it gives you an overall score. And there's two, I've included the results here from two of our tools. So the risk of bias tool is looking at RCTs, and the Robbins I tool is looking at non-randomized studies of interventions. But we did use some other risk of bias tools as well, but we haven't included them here to just try and avoid some brain overload. But suffice to say, there was a wide variety of results from those as well. So we've talked a bit about them, and essentially what you're wanting out of a risk of bias ideally is to get a low risk of bias. And so the fact that we're getting some concerns, high or moderate, serious and critical, suggests that there are some concerns amongst most of these papers as to how likely we are really kind of getting a good idea of the intervention effect. But I also want to just briefly pause to have a brief discussion or a brief moment to talk about why I think one of the reasons that these were these papers were getting these ratings. And that is that some of the outcomes that I was wanting to, because the number of papers was so small, we were wanting to include any study that met criteria and mentioned outcomes that were relevant to us. So sometimes a study would have outcomes related to substance use, but it would be a secondary outcome for the paper. And so the paper, the authors of the paper, their reporting may not have been as rigorous for that particular outcome. So then when I'm conducting the risk of bias assessment, I don't have as much information to be able to figure out how likely that intervention was to be at risk of bias, essentially. So that's one reason why there may be some higher ratings in there. So these were the key outcomes of interest that I introduced before. So we were looking at substance use, overdose, retention and treatment, adverse events, and recidivism. So for both medications, not every study reported on each of these outcomes, which isn't necessarily surprising because many would instead choose to focus on one particular area in greater detail. So what I'll report on in the coming slides is the number of studies that reported on each of these outcomes and if there was any effect. So if we're starting off with substance use, I just want to talk a little bit about the theory here of why the extended release medications may be more efficacious in reducing substance use than their daily dosing counterpart, which are kind of pharmacologically very similar. And the theory is that a more steady level of the medication in the bloodstream, if you're just receiving that, say, injection every month, may allow for more stability in terms of cravings, if the medication has an effect on cravings, which extended release naltrexone, for example, doesn't. And that the ease of use of just having the injection once a month means less missed doses. And again, that means a more stable level of the medication in the blood, hopefully a higher therapeutic level as well, and less chance for withdrawals and cravings, which may then result in use. This is a particularly important outcome when you're leaving prison, because as we've already discussed, there's a very high chance of relapse in that post-release period and limited access to in-depth treatment programs in many jurisdictions in prison and immediately on release. So what did we find? So for extended release naltrexone, we found no clear direction of effect, but the outcome was reported in 10 out of the 16 studies. And the reason we can't land somewhere more solid with this is that there were significant concerns with some of the comparator groups used, and many of these studies had high risk of bias scores. So we can see that 3 out of 10 studies had a greater reduction from the extended release naltrexone than the comparator. And the comparators are listed there on the side, but I won't go into the detail here, but essentially there are concerns around these comparison groups. Then there was no effect found from the extended release naltrexone for opioids compared to these comparator groups. And there was mixed effects found in one study when looking at opioids, which means there was no change in substance use areas and some improvements in others when compared to placebo. So because of that, we're unable to really make a kind of strong statement about the extended release naltrexone. Moving on to the extended release buprenorphine. So this was exclusively looking at opioids, as I've discussed before, and the outcome was reported in 2 out of the 7 studies. So we can see that there was, in one study, we saw a reduction in use over time, but that wasn't compared with the comparator arm, which was methadone. And in another study, we saw no effect compared to sublingual buprenorphine. So obviously, this statement at the top the statement of some evidence comes with the caveat that it's only 2 studies. But what makes me a little bit more definite than the previous studies, which actually there was a greater number that we could draw from, is that the comparator here of the sublingual buprenorphine has quite a strong evidence base already. And so to have no effect compared to sublingual buprenorphine still likely means that there is a good effect from the extended release buprenorphine. But certainly we need more studies to be able to make a definitive conclusion. So moving on to overdose. So again, I just want to give a little bit of background about why we're looking at overdose. Obviously, it's important to be able to prevent overdoses, but why these medications for overdose? So we talked in the beginning about how naltrexone is a blocker of opioids. And so the oral formulation, there have been some studies and some evidence around it potentially reducing overdose, but because it's a blocker, it also reduces tolerance to the medication. And that reduction in tolerance can mean that if someone isn't covered by the medication, so they've stopped taking it or it's not at a high enough dose or whatever it may be, that person may actually be at an increased risk of overdose compared to before starting the medication. So a considerable concern with the naltrexone and something that really needs to be clear in the literature if we're looking at using it. Didn't actually say earlier, but naltrexone in Australia extended release naltrexone isn't available routinely. There was some special access through the TGA. I'm actually not sure if that's still available, but it certainly is not routinely used. I've never prescribed it. The buprenorphine, however, the sublingual buprenorphine, has got good evidence showing a reduction in overdose. And so that's because it's an agonist, as we discussed before. So there's less effect on the tolerance. And so we're not going to see that increase in overdose because of a reduction in tolerance. It's also a strong binder to the receptors. So that means that if you have been taking Suboxone, buprenorphine, or extended release buprenorphine injections, and you use heroin or some other opioid, it's difficult for the heroin to knock the buprenorphine off the receptors in the brain. And the buprenorphine has less of a kind of respiratory depression effect, which is essentially what an overdose is. So it's protective in that mechanism, in that the heroin just can't quite get onto the receptor. It also works by reducing overdoses by just reducing cravings for use, which is an important difference to naltrexone. So if you have less cravings for use, you're less likely to use and you're less likely to have an overdose. So I guess the difficulty with trying to make an assessment with these studies, however, was that there were quite low numbers of participants in the studies looking at overdoses. And as a result, there were generally low numbers of overdoses, which is great. But it does mean that we're not able to really see an effect from either of the medications. So when we're kind of looking at the studies that compared the arms of their studies, we saw that there was no real statistically significant effect between the two comparators. For extended release naltrexone, it was reported in 4 out of the 16 studies, and that's the number of overdoses in those studies, so 0, 0, 3, and 16, quite low numbers. And for extended release buprenorphine, it was reported in 2 out of the 7 studies, both of which had no overdoses. So moving on to retention in treatment. So given that this medication means less kind of hustle to get the medication for patients, we thought that retention would be a reasonably clear-cut one, at least for extended release buprenorphine. But what we actually found was that for extended release naltrexone, the comparator groups again really hampered us. They limited our ability to make an assessment. The outcome was reported in 4 out of the 16 studies. And I guess it's important to note as well that there were small to moderate sample sizes in those studies and pretty variable follow-up periods as well. So there was no change in retention in one of the studies versus placebo. I've got this other study grayed out here because that did originally show that there was no change in retention, but it was a preliminary analysis. This is the subsequent analysis below, and that showed improved retention for the extended release naltrexone. So really only one study showing no change in retention, and then 2 studies showing improved retention, but these studies aren't really the best representation. And the reason for that is that this methadone comparator study was looking at the comparison of an implant, an extended release naltrexone implant versus methadone. And the definition of retention in treatment was not having presented to have the implant removed, not necessarily coming back to have a second implant put in. It was a 6-month implant. So that definition has some issues. The other difficulty with this study was that it was a randomized study to either the implant or the methadone, but methadone was actually freely available in the prison network, but on prescription, without being in the study. So patients that were motivated to be on methadone were generally already on methadone. And so the selection of people that were happy to be randomized to a study was quite a subsection of that prison overall. And the methadone arm had very low retention rates, which is uncommon and at odds with the international literature and certainly the literature from Australia. There's also the other study looking at improved retention compared the medication given pre-release to post-release, which is also a complex one because it was measuring the number of weeks in treatment, which when you're receiving it pre-release in an institutionalized setting, there's certainly some kind of bias there that could impact rating. So looking at retention in treatment for extended release buprenorphine. So this outcome was reported in 4 out of 7 studies. There were small to moderate sample sizes again with variable follow-up periods. There was none of the studies compared arms, but I did do some analysis of one of the studies and found that the extended release buprenorphine seemed to have greater retention than the sublingual buprenorphine. And the raw percentages reported in 2 of the papers were quite high for retention. So 70% retained while incarcerated and 92.3% in another study, the treatment retention probability there. There was a 4th study, but that was a case series, and that just showed 4 out of 6 people in that case series were retained, so not particularly useful data. So adverse events. So adverse events are essentially side effects. So what we were hoping to understand with this was not necessarily the specific side effects that were reported or adverse events reported, but we were hoping to understand if there were a greater number of adverse events reported compared to existing treatments. And really we were unable to assess for any change in reporting of adverse events. And that was because of but we were able to see a high percentage of reported adverse effects for extended release buprenorphine. So we couldn't see a change, but we saw that a high percentage did report effects. So one of the difficulties here was that there was a wide variety of reporting mechanisms for adverse events. So some studies were reporting the number of adverse events, others the number of serious adverse events, others the number of people with adverse events, and on and on. So that just really limited our ability to kind of create comparisons across studies. So for extended release naltrexone, 10 of the studies did report on adverse events, but 2 of them showed no change versus placebo. And that was from the same study actually, but 2 papers. And 8 of those papers, we weren't really able to make an overall assessment. Sometimes they had results for one arm only. Often they had incomplete reporting about this. So that's why I haven't included much detail up there on that. For extended release buprenorphine, 4 out of the 7 studies reported on adverse effects. And these are the percentages down here, which as you can see are quite high. So 60% in one sample and 97% in another sample. And 2 papers had minimal reporting. So onto recidivism. So why this was an important outcome for us to look at was because around 42% of people leaving prison will reoffend and be re-imprisoned within 6 months of release. So very high percentages of people coming back into the prison network. And this rate is significantly higher for people with a history of substance dependence. So the general premise around how treatment may affect recidivism is that people are often incarcerated for drug-related crimes or to fund their substance use. And stable treatment may be able to help reduce those crimes. But given what we've seen so far in the rest of the data, you might be able to guess what we got with this. No evidence for a change in recidivism from extended release naltrexone. Outcome was reported in 8 out of 17 studies. So there was no difference. 5 studies found no change between the groups, and that was across 6 papers. But these are the comparator arms over here. And I guess these ones that I've underlined, I've just underlined them to focus in on the fact that these are really the only 2 that we can properly look at, because again, these comparator arms down here just aren't the most useful for looking at recidivism. And then there were 3 studies that were really unable to assess an effect from the extended release naltrexone due to the comparator groups. I won't go into that detail. Extended release buprenorphine. So look, there was no evidence for a change in recidivism from extended release buprenorphine, and it was reported in 2 out of the 7 studies. So 1 study found no change between extended release and sublingual buprenorphine, and 1 study had no comparator group, but did just report that 7 out of their 33 participants were reincarcerated. So we're nearly at the end of the results, and we'll get into the discussion shortly, but I just want to pause here quickly and just briefly discuss this, the 1 qualitative paper that was found. So this was looking at extended release buprenorphine. And the aim of it was to to describe the treatment experience, treatment satisfaction, barriers and facilitators to extended release buprenorphine initiation in jail and retention post-release amongst the prisoners. And the reason I wanted to talk about this is it just kind of adds a little bit of richness to what we were just talking about. So in terms of retention and treatment, the participants in this study were saying that they were feeling that kind of normalcy that I spoke about earlier. So they just noticed a relative lack of withdrawals or cravings than they had on the other types of medications. And because of that, they felt more inclined to remain on the treatment. A number of participants spoke about the effect that they felt it would have on their employment, that it would be much easier to work on the outside, but also within the prison system when you're not needing to attend for daily dosing. And there were high levels of satisfaction among the participants in this study. They reported satisfaction with the lack of withdrawal on entry to prison. And so what they're meaning by that is that it can be complex when you first come into a prison to see a prison health worker and access, say, opioid substitution therapy, even if you are on it in the community. So sometimes people would be on Suboxone or methadone, but when they entered prison, they had to go a few days without getting their dose. Having the extended release buprenorphine meant that in that period, they didn't go into withdrawal and they could, again, just get all of their ducks in a line in the prison system. They also spoke about liking the reduced attention from the prison guards and a bit of privacy as well around their health conditions. Some talked about how there would be overhead announcements when it was time to come and collect the pharmacotherapy. And so just getting the monthly injection reduced that down. In terms of the adverse events, so some did report a significant post-injection pain and one discontinued use, and some did report persistent withdrawal symptoms. The challenges were quite interesting. So one of the major things for this population, so this study was done in the United States, and the clients were talking about the barriers to resuming the extended release buprenorphine in the community around the availability and the cost, which certainly is a consideration here, probably to a lesser degree than in the States, but for some clients can be difficult to manage the cost and the availability of providers. There was also, interestingly, some issues around missing the regular dosing of the medication. So that behavioural and ritual component was quite important. And there was some needle phobia concerns. So on to the discussion. So this is just a summary of all the outcomes, and I've just circled the outcomes with an evidence of effect here. So in terms of extended release naltrexone, no clear direction of effect for substance use, some evidence among extended release buprenorphine, some evidence of reasonable retention for extended release buprenorphine, but not so much for extended release naltrexone. Overdose and adverse events aren't really able to make an assessment, and recidivism, there was no real evidence for a change of effect. So the research takeaways, I guess the major thing is that we really do need some greater consistency going forward in future studies about the definitions, variables, measures, comparators, methods, and analysis. And at the moment, there are kind of relatively small numbers of participants in many of the studies with variable follow-up times. So trying to improve each of those areas and get some more consistency would be helpful. But again, I've acknowledged before, prison research is tough. It's hard to conduct ethical research in prisons at times. It's hard to get access at times to the clients. It's hard to maintain links on release. The funding models can be incredibly complex, with them existing outside of Medicare. So yeah, prison research is a very tough area, but I certainly think some investment in it would go a long way. And again, I just want to reiterate here that the lack of evidence is not the same as evidence of non-efficacy for these medications. We do need more evidence before we can make that judgment. So just back to the clinical takeaways. I guess I feel like the evidence at the moment doesn't really support the anecdotal experience of myself and many of my patients. So this is particularly for the extended release buprenorphine. As I said before, we haven't got use of the extended release naltrexone here. Many patients, not all, certainly not all, but many patients do report kind of greater flexibility from the medications. I do feel like there is a much better coverage over that risky period post-release, and it's certainly less resource intensive. I will continue to offer it in the prison sector in South Australia. There's often actually limited other options, and that's because of diversion, which was one of our other outcomes. So you have to have quite a good reason to go with sublingual buprenorphine rather than extended release. But when I'm counselling people around the extended release buprenorphine, I guess I'm using kind of talking much more about the theory versus the evidence. So I'm explaining the theory around why we think it could have more of an effect on substance use outcomes and overdose, rather than saying that it's kind of based in the evidence, because it's not. Extended release naltrexone, I'm not counselling around that, but if I was, I'd be saying that there's very limited evidence for both alcohol and opioids. So strengths of the review, we used a rigorous approach, strict eligibility criteria, and it was PRISMA compliant. Combining the extended release medications with two very different pharmacologies, however, was certainly a limitation, and we've discussed that throughout, but I still think it's important, particularly around that retention and treatment, to look at the two combined. And I guess just to have a little think about whether it's answered our research question. which I've just put there for you to refer back to, but largely no, more research is needed on both medications. And certainly we still need more research in terms of the relapse prevention and the recidivism outcomes. As I said, my particular interest focuses around Aboriginal and First Nations people, and I don't feel able to kind of comment on a particular direction that we need to go in research for Aboriginal or First Nations people at this stage, because there's still not enough evidence in the general population for us to really be able to see where that's going to head with the Aboriginal and First Nations groups, but a very important area that needs some particular focus. So where to for extended release research? So the evidence is emerging for the use of evidence is emerging as the use of extended release buprenorphine picks up. So it is a very common treatment at the moment. And so we really have the opportunity because of that to do ground up really good quality research, because there is a high number of people that are on the medication. And so we can really kind of delve into this area and learn more about it. I think it would be wonderful to get a much greater depth and breadth of ideas around the experience of clinicians and patients, and more studies with more participants and less variability to compare outcomes effectively would be great. So where to from here in my research? So I'm wanting to know how to best serve the treatment needs of Aboriginal people with substance use disorders in contact with the criminal justice system. And I'll be conducting a qualitative study looking at perspectives of Aboriginal patients on extended release buprenorphine and doing some analysis of clinical screening data about treatment needs. Just want to do a quick thank you to my wonderful supervisory team and the lovely team at NDARC who've all been wonderfully supportive, especially Daisy, and to the village that helped me do this research amongst having 2 young kids. So keen for questions now. Daisy, I'll hand back over to you.
Thank you so much, Amelia. Such a comprehensive piece of work and such an interesting area. I will ask you to stop sharing your screen and invite Adrian and Kath to turn on your cameras and join me in congratulating Amelia on a great piece of research and a wonderful presentation. So we've got a couple of questions coming into the Q&A. Please keep them coming. And to get us started, I might turn to our panelists to get some quick thoughts. Kath, I'll give you 30 seconds to give us your impressions of Amelia's work. Yeah, what are your thoughts on this?
Terrific. Thanks, Daisy. And good afternoon, everybody. Congratulations, Amelia. That was a really interesting presentation. Not easy to do with such dry work, so well done. I think what I find particularly captivating about your work is the way you positioned it within a clinical and person-centred context. It's really useful to consider what a systematic review can do by highlighting the evidence, and equally by identifying how a stronger evidence base can be built, given that it's being used, so widely at the moment. I really like your point about this opportunity to do some really good research and have an impact for people and the informed choices that they can make about their care. So well done.
Yeah, thanks, Kath. And yeah, echo that. Well done, and such a great positioning. And speaking of opportunities to do great research, Adrian, what are your immediate thoughts on Amelia's presentation and the work she's doing?
Thanks, Daisy. And yeah, echo Kath's thoughts. It's great to see clinician researchers emerging. It's great to see somebody coming with a practical question that they see in a clinical environment, trying to best answer it. Unfortunately, the rigour which you've demonstrated today of going through the systematic review process, when you really try to shake out the evidence, don't find too much in this area, and that's probably because we're still relatively early in the piece. You made the point well, I think, Amelia. Research in prisons involving populations in prisons coming out of custody, it's really difficult stuff to do. Takes a lot of resources and a lot of cooperation from a lot of people, and therefore, is just practically hard to do. And the base from which to do this sort of research really only exists in Europe, a very small number of states in the US. Most states, it's impossible in the US to have opiate treatment in prison still. Sadly, Australia was one of the leaders, Kate Dolan, and others, great leaders in establishing methadone. It's great that we've got it in all states in Australia. But beyond that, so there's the pool of where you could do this research and collect this research from is disappointingly small. You did make the important point, but I just want to reiterate it. For a whole bunch of reasons, our American colleagues continue to try to see a glass that's got any water in it with extended release naltrexone, and I really just don't think there's much there for most people. We don't have access to that in Australia, so it's not, you can't extrapolate from oral naltrexone to what you've seen with Vivitrol. Australian researchers have tried to access Vivitrol for research in Australia and have been unsuccessful. Unfortunately, the parent company hasn't been willing to provide it. So yeah, important that we don't, you can make some jumps from sublingual buprenorphine to extended release buprenorphine, but you can't from oral naltrexone to extended release naltrexone. So great that you pointed out. And so what were the two sort of key things? Some evidence about reduction in use, and some evidence about retention treatment with extended release buprenorphine. I guess it's important to jump back and think, well, in non-custodial populations, has that been demonstrated? Yeah, it has, and it has pretty, at RCT level at least. So it's probably going to be the same in this population, but of course, very important to think about it. The question you had at the end, it was a really good question coming back to, why you started this. What does this mean for Aboriginal people? It does mean a lot, I think. So there's something like about 3,500 people in custodial centres in Australia on extended release buprenorphine. Thus, over 50% of all the people on opiate treatment in custodial centres in Australia. In New South Wales, for example, it's 80%. And sadly, Aboriginal people are well and truly overrepresented in prison stats, as you've recognised. And so this does, over proportionally affect them, and so that's why we've got to understand, does it work well? But I'll stop there and thank you. Really enjoyed your presentation, and we should move on to trying to answer some of the questions.
Thanks so much, Adrian, and thanks, Kath. And I think you kind of touched on a few of the questions that are coming in already, whether inadvertently or you're reading at exactly the same time. I will turn to some of the questions now. And there are a few. Please do bring them in if there are questions that we pick up, and we will get a copy of these, and Amelia may be able to correspond with people following this because we might not get to all of them. But a question from Amelia Berg. I know that you commented, Amelia Woods, on the one qualitative paper that you were able to identify. But as a clinician, and would be keen to hear your thoughts as well, Adrian, having been involved in a lot of research and being across a lot of the rollout, just speaking to the acceptability and patient preferences regarding treatment types. And again, acknowledging this is anecdotal experience on your behalf, but just Amelia in the questions here has acknowledged that there is potential for some concern that extended release buprenorphine could be implemented in a way that removes patient choice. I feel that lack of choice or not being offered treatment that patients find acceptable would result in people dropping off treatment upon release, amongst other, moral and ethical concerns. So yeah, keen to hear your thoughts, Amelia, and also Adrian.
I'm very keen to hear Adrian's thought, because I grapple with this really. It's certainly, there's very good reasons in the prison sector why we're moving towards a strong emphasis on extended release buprenorphine, more so than in the community, but it is happening in the community as well. But I'm not sure if Adrian, if you also feel a bit uncomfortable with it, but there is like a slight level of tension there that I do see the benefits around diversion and during lockdowns in the prison, you're making sure people getting access to their medication. So there's a lot of benefits there, but it is starting to feel like there is a little bit of a lockout away from the sublingual.
I'll quickly go from the ideal to the real. The ideal, we shouldn't be sending people to prison for drug-related offences, and we keep doing it, and no jurisdiction in Australia is brave enough to stop doing that. But we do. In that context, typically governments are nowhere near as enthusiastic as providing access to health services in prisons as they are creating new prisons and building new prisons. In that environment where there's an undersupply of health resources, pragmatically, this is way cheaper. It's a tenth as cheap as sublingual buprenorphine and a quarter or a third as cheap as methadone, and that's why it gets offered. Should that be also? No, we should have access to all medications equally and it be patient choice, but that's where things are at.
Yeah. Great to get that perspective. I want to give a nod to these comments from Emma Clow, who is making essentially requests for you to come to Mulleridge to do some further research. So she works in a prison in Far North Queensland, the prison where she works over 75% First Nations. So welcoming in a seemingly quite encouraging way to go up there and do some research, have you the capacity. And more of just a comment about the reduction in recidivism rates by about 35%. This was in 2018, but related to Suboxone only. But yeah, keen to see the impact of extended release there. And just wanting to give some congratulations to you, Amelia. Congratulations and thanks, Adrian and Kath, from our Q&A. We have also a question here about sorry, trying to keep up, about from Brodie Clark. Obviously understanding that there are challenges in comparing retention between daily dosing and extended release formulations, but wondering if there are any particular approaches that you recommend or challenges that you've encountered in doing so. So I guess that's coming from a comparing different treatment modalities and retention in these. I might put that to you first, Amelia, and then thoughts welcome from Kath and Adrian.
So just quickly, so it's around how to compare retention for oral versus extended release. Yeah. So obviously it's much easier with oral because you've got the regular daily pickups. And that was one issue with the implant in particular, is you've then got like a 6-month retention. So I guess I do think that treatment coverage is one of the major things we're looking at. So potentially moving to treatment coverage, while it doesn't then show treatment acceptability, it's still an important marker. So maybe measuring the two alongside each other gives us that full idea. I'll move on. I know we're time pressured.
Yeah. Do you have any thoughts on that, Adrian?
Yeah, quickly. So we've used the practical definition. When would you need to write a new prescription? With sublingual buprenorphine, that's usually within a few days because of state dosing regulations, but within depot it's several weeks. So it's different.
Yeah. And Kath, any thoughts on that yourself to add to Adrian and Amelia?
Well covered, I think. Thank you. Thanks for asking.
Thanks, guys. I'm really sorry to the three of you and to the audience not be able to get into further questions, but we are going to have to wrap up. I would just like to say thanks again so much, Adrian and Kath, for joining us, and thank you so much, Amelia, for a really interesting presentation and on such a complex issue, crossing so many different areas of complex health delivery and research. I think you've brought together a really diverse and challenging area of literature really well, and also highlighting the fact that given that this is an emerging area of treatment and therefore research, it's not necessarily a reflection on terrible research or terrible evidence, as you say, but it's an opportunity for doing powerful, rigorous research into the future. And I think this systematic review will contribute to the kind of research we want to be seeing as things progress. So thank you all so much for joining us, and thank you to the audience for joining us and for questions. I'll ask Julian to put on the promo slide for upcoming webinars over the next few weeks. So we've got here 8th of June, that's today. Everyone was lucky enough to join us for Amelia's presentation. Next week, we've got Anders Losnes looking at predictive models in substance use prevention and care, the pitfalls and opportunities. Following that, we'll be looking at enhancing the detection and management of hazardous alcohol use in older adults, and that's with Associate Professor David Newcomb. And on the 29th of June, our very own Dr. Kriana Barrett will be looking at agreement between self-reported illicit drug use and biological samples as results from a systematic review and meta-analysis. So thank you all again for joining us. Thank you, Amelia, Adrian, and Kath, and have a wonderful afternoon.